ವ್ಯಾಕ್ಸಿನ್ ತೋಡಿ 4 ಆಗಿದೆ, ನಮ್ಗೆಲ್ಲ 3, 4 ಮೋಷನ್ ಅಲ್ಟ್ರಾಸೆಟ್ ತಗೊಳ್ಳಿ ಪೇನ್ ಇದ್ರೆ. ಕೆಮ್ಮಿದ್ಯಾ?
ಕೆಮ್ಮಿಲ್ಲ, ನೆಲ್ಲಿಲ್ಲ, ಏನಿಲ್ಲ, ತಲೆಭಾರ ಇಲ್ಲ.
ಕೆಲಸ ಮಾಡಿ, ಈ ಕೇಸ್ ಇವತ್ತು ನೋಡಿ, ನಾಳೆನೂ ಕಡಿಮೆ ಆಗಿದ್ರೆ ಒಂದು ಬ್ಲಡ್ ಚೆಕ್ ಮಾಡಿದ್ದೆ. ನನ್ನ ಪ್ರಕಾರ ನಾರ್ಮಲ್ ಇದ್ದೀರಾ, ಏನು ಸಮಸ್ಯೆ ಇಲ್ಲ. ನಿಧಾನ ವೈರಸ್ಗಳು ನಾವು ಆಂಗ್ಸೈಟಿ ಮಾಡ್ಕೊಂಡಂಗೆ ಅದು ನಿಧಾನ ಬೇಕಂತ ಆಟಾಡ್ತದೆ. ಮಾಡ್ತಿದ್ದಡಿ ಇವರಿಗೆ. ಅಯ್ಯೋ
ನಾನು ಸುಮ್ಮನೆ ಹಾಕ್ತೇನೆ.
ಎವ್ರಿ ಮಂತ್ ಸ್ವಲ್ಪ ಮೈ ನೋವು ಅನ್ಸ್ತಾರ 3 ದಿವಸ
ಅಲ್ಲಿ ವಿಸಿಟ್ ಮಾಡಿ
ಅದೇ ತಗೊಳ್ಳಿ, ಎಲ್ಲ ಸರಿ ಹೋಗುತ್ತೆ. ಅವ್ರಿಗೂ ಹೇಳಿ ಏನ್ ಗಾಬರಿ ಆಗ್ಬಿಡಮ್ಮ, ನೋಡಿದೀವಿ ಸರಿ. ಗೋಲೋ ಜ್ವರ ಬಂದಾಗ ತಗೊಳ್ಳಿ, ಅಲ್ಟ್ರಾಸೆಟ್ ಪೇನ್ ಬಂದಾಗ ತಗೊಳ್ಳಿ, ಕೋಲ್ವೇಟ್ ಎಂಜಿ ಇನ್ನೊಂದು 5 days ತಗೊಳ್ಳಿ. ಮೋಷನ್ ಆಯ್ತಲ್ವಾ? ಆಂಟಿಬಯೋಟಿಕ್ಸ್ ಏನು ಬೇಡ ನಿಮ್ಗೆ, ಆರಾಮಾಗಿರಿಮ್ಮ. ಇಲ್ಲ, ಏನ್ ತೊಂದ್ರೆನೂ ಇಲ್ಲ, ನಿಮ್ಗೆ ಯಾರಿಗೂ ತೊಂದ್ರೆ ಆಗಿಲ್ಲ. ಅವರು ಪಾಪ ಪ್ರೀತಿಯಿಂದ ಹೇಳ್ತಾರೆ, ಗಾಬರಿ ಆಗುವಂತದ್ದು ಏನಿಲ್ಲ. ನೋಡಿ ಬೇಕಾರೆ ಅದೇ ಬರ್ಬೇಕು ಅಂತಿಲ್ಲ. ಸಪೋಸ್ ನಾಳೆ ಒಂದು ಸರಿ ಹೋಗ್ಬಿಟ್ರೆ ಬರೋದು ಬೇಡ, ಮಂಡೇ ಮೇಲೂ ಸರಿ ಹೋಗ್ಬಿಟ್ರೆ ಬನ್ನಿ ಅಷ್ಟೇ. ಹೆಂಗ್ ಗೊತ್ತ, ವೈರಲ್ ಫೀವರ್ ಎಲ್ಲರಿಗೂ 1 ವಾರ ಕಡಿಮೆ 10 ದಿನ ಆಗುತ್ತೆ. ನಾವು ಗಡಬಿಡಿ ಮಾಡಿ ಬ್ಲಡ್ ಚೆಕ್ ಮಾಡ್ತೀವಿ ಎಲ್ಲ ನಾವು. ಡೋಂಟ್ ವರಿ. ಮುಗಿಲಿ ಸ್ವಲ್ಪ, ಇವಾಗ ಸ್ವಲ್ಪ ಸೆಟ್ಲ್ ಆದ್ಮೇಲೆ ಇಬ್ಬಿಬ್ರು ಶುರು ಮಾಡ್ಕೊಂಡ್ಬಿಟ್ರೆ. ಏನ್ ಮಾಡೋದು, ಈಗಿನ ಹುಡುಗಿರಿಗಳೇ ಹಾಗಲ್ವಾ? ನಿಮ್ಮಿನ ಇದು ಮೆಚುರಿಟಿ ಇರಲ್ಲ. ನಿಮಗೆ ಮೊದಲನೇ ದಿನಕ್ಕೆ ಇವತ್ತು ಓವರ್ ಕಡಿಮೆ ಆಗ್ತದೆ. 2-3 days ಬಿಟ್ರೆ ಅದೆಲ್ಲ ಇದ್ರೆ ತಗೊಳ್ಳಿ. ನೀವು ತಗೊಳ್ಳಿ ಅಂತ ನಿಂಗೆ ಇಟ್ಬಿಡಿ. ಎಲ್ಲ ಹೇಳೋದೆ ಹೋಗಿ ನೋಡಿ ಅಂದ್ಬಿಟ್ಟು ಅವ್ರು ಆ ಕಡೆ ಹೋದಾಗ ಸ್ನಾನ ಮಾಡ್ಕೊಂಡು ಬಂದಿರೋ ಫಸ್ಟ್ ಕ್ಲಾಸ್ ಇರುತ್ತೆ. ಏನು ಬೇಡ, ನೀವು ನಿಮ್ಮಷ್ಟು ಆರೋಗ್ಯವಾಗಿ ಯಾರು ಇದ್ದೀರಾ. ಆರಾಮಾಗಿರಿ, ನೀವು ಖುಷಿಯಾಗಿರಿ. ಯಾರು ಗಾಬರಿ ಮಾಡೋದು, ನೀವೊಂದು ಗಾಬರಿ ಆಗ್ತೀರಿ. ನಾಳೆ ನಾಡಿದ್ದು 2 ದಿನ ನೋಡಿ, ಪುಷ್ಟಿಯನ್ನು ಕಡಿಮೆ ಆಗಿಲ್ಲ ಬನ್ನಿ, ಚೆಕ್ ಮಾಡ್ತೀವಿ. ಅಷ್ಟೊತ್ತಿ ಎಲ್ಲ ಕಡಿಮೆ ಸರಿನಾ? ಏನ್ ಎದುರು ಬಿಡಿದ್ವ ಮಗಳಿಗೆ ಹೇಳಿ, ಆರಾಮಾಗಿರಕ್ಕೆ ಆಯ್ತಾ? ಆಯ್ತು. ಏನ್ ಮಾಡೋದಮ್ಮ, ಕೆಲವೆಲ್ಲ ನಮ್ಗಲ್ದಾದ್ರು ಬೇರೆಯವ್ರಿಗೆ ಹಾಸ್ಕೊಂಡು ಹಿಡಿತಾರೆ. ಯೂಶಲಿ ಅಷ್ಟೇ, ಅಮ್ಮಂಜಿನ ಮಗಂಗೆ ಅಪ್ಪಂಜಿನ ಮಗಂಗೆ. ಏನು worry ಮಾಡ್ಬೇಡಿ. ಎಕ್ಸಾಮ್ ಮಾಡಿದ್ರೆ ಚೆನ್ನಾಗಿಲ್ಲ ಬರೀಬೇಕು. ಹೌದು.
Good evening, sir.
Good evening.
So all are joined, I think.
Yeah. Good.
Some, somebody has shared his screen already. I don't know who's. Yes, sir.
ಏನ್ ಪರ್ಮಿಷನ್ ಇಲ್ಲ, ಏನಿಲ್ಲ, ಯಾವ ಬೆಂಗಳೂರಲ್ಲಿ ಇದ್ರೆ ಇದ್ದಿದ್ದೆ. ಇಂಜೆಕ್ಷನ್ ಎಲ್ಲ ಕೊಡದೆ ಯಾವ ಕಾಲ ಆಗುತ್ತೆ? ಏನಕ್ಕೆ ಇಂಜೆಕ್ಷನ್? ವಾಂತಿ ಇರೋದು ಇಂಜೆಕ್ಷನ್.
Hello, good evening, all and everyone. That on behalf of Cipla, I am very glad to invite you all. Sorry for the inconvenience. Behalf of Cipla, I am welcoming you all here for Strengthening Heart Expert Summit. Dear doctors, we are delighted to invite you for the Strengthening Heart Expert Summit on MRI in heart failure. Dr. Moderator, Dr. Major JAYAPRASAD V, MD, Medicine, DNB, Cardiology, Consultant Cardiologist, East Point Hospital, and Dr. Rajendra Kumar HN, Consultant Physician, Shraddha Clinic, Dr. Karthik SM, Consultant Physician, NH Hospitals, Dr. N. Vijay Kumar, Consultant Physician, Sri Venkateshwara Hospitals, Dr. Jonita Fattadu, Consultant Physician, St. John's Medical College and Hospital, Dr. Divakara P, Consultant Physician, Divakara's Clinic, Dr. Bhanu Kumar M, Consultant Physician, JSS Hospital, Dr. Chandan Kumar HN, Consultant Physician, Leela's Clinic, Dr. Srihari US, Consultant Physician, Sanjeevani Clinic. I am welcoming, behalf of Cipla, I am welcoming all. Sir, JAYAPRASAD sir, over to you, sir. Hello.
Good evening, all.
Yes, sir, you can start.
Are you able to hear my voice?
Yes, sir. Yes, sir.
Okay. And
Sir,
actually, since I am connected with the mobile. If the voice or anything gets interrupted, please bear with me.
fine, sir.
Yes.
Before that, sir, my sincere request, can you please switch on your video, sir?
All
I have
of you.
switched on the video.
Not only, sir. Sir, all doctors, my sincere request, please switch on your video, sir.
I have switched on my video as well
Yes,
as
sir.
unmute
Yes.
also.
Yes, sir. All the doctors.
shall we start?
Sir, just
Yes,
2
sir.
minutes.
Please go ahead, sir.
Okay. I think actually almost all the actually faculty members have joined, and one thing is I believe that actually all the faculty members might have gone through the PowerPoint presentation. And being a Saturday evening, and just we wanted to be straight on the point. My only actually request to all the senior faculties or who are the faculties who have joined here, it's better actually rather than being a one-way communication, let us have an interactive session, because heart failure definitely more than me, you all as a general physician, you will have more chance of actually coming across more number of patients and treating them more than a cardiologist per se. And nowadays, as you know, that actually most of the cardiologists concentrating towards only on interventions, the real quality care of the cardiac failure, heart failure, it is actually a domain of physicians nowadays rather than actually a cardiologist. So my sincere request is, along with the slides, actually if you all yourself come give your opinions, give your thoughts, or we can share our queries so that it will be mutually beneficial for everyone involved. So my suggestion is, then and there, every one of the participants, please interfere at then and there and actually start a dialogue rather than a monologue. Have everyone got my point?
Sure, sir. You can go ahead.
Yeah. So we will go for the next slides. Let me actually, before starting this, can every one of you actually give an individual opinion? This talk, the present today's talk, what are the things you are actually looking at, or actually what are the inputs you wanted to give to the general population, and what are the things, if you have any queries and everything, if you have got and everything, so that we can address among ourselves mutually and then clarify. Otherwise, I am sure that all of you might have gone through the PowerPoint presentations. There is no doubt about the incidence and prevalence of heart failure in the general community, and what is the latest class 1 indications in which it is actually AC inhibitors, ARBs, ARNIs, all beta blockers, ivabradine, SGLT2 inhibitors, mineral receptor antagonists, and diuretics. Everything has got a class 1 indication which we all are aware. So you all actually come out with input of how actually you people are starting actually heart failure therapy, and what are all the actually difficulties that you all are having. One by one you can start everything. You can introduce yourself and then actually start whatever actually you wanted to give input to us.
Sir, Rajendra Kumar sir, you are in mute, sir. So please unmute yourself.
Now can you hear me?
Yes, sir.
Good evening, sir. Please tell me, sir.
Okay. See, basically, physician, we come across patients, and they will not come with cardiac failure symptom. Majority of them, they may have a very minor symptom, because there are a whole lot of spectra. Many patients present without symptoms also, and symptoms of overload. Heart failure is not congestive heart failure. Nowadays, it is called heart failure. So it's a very major problem. So we should have always a high degree of suspicion, especially in setting of high risk group patients like hypertensive, coronary artery disease, and diabetes, etc. So we should make an early diagnosis to prevent problem or prevent hospitalization of heart failure. So when we see the patient, the history is more important, and also the examination. Go back to the previous MBBS, those days in MBBS when we used to take a lot of history, examination. So those things will help in making diagnosis of heart failure. And as everybody knows, heart failure with reduced ejection fraction with preserved ejection fraction. So we can make out the diagnosis at the earliest, and then if possible treat in our own setting or refer to a cardiac center.
Sir, I am completely actually concur with your actually insight. As you rightly pointed out, heart failure by definition is a syndrome. It's a syndrome of signs and symptoms suggestive of actually reduced cardiac output or actually reduced actually supply demand mismatch or something. So that's the reason previously we used to involve only the heart failure with reduced ejection fraction, but nowadays actually mid-rate ejection fraction and even heart failure with preserved ejection fraction also has come into picture. So most important thing, like you suggested, it is the symptoms and signs. So the basic symptoms of actually orthopnea and paroxysmal nocturnal dyspnea. We should not never forget a person who has presented with actually exertional dyspnea. That means he is already having actually some filling pressures. Already the left atrial pressures have gone to actually beyond 15 to 20. The moment the same patient has comes with the paroxysmal nocturnal dyspnea, that means the pressures are already gone to actually 20 to 25. By the time when he reached the hospital with the orthopnea, then actually these filling pressures have reached beyond 25. So it is dyspnea, but like he's told, dyspnea can be because of lot of complaints. It can be anemia per se can cause failure, or lot of COPD patients we are coming across nowadays. And apart from that, actually there is a generalized actually secondary dyspnea, metabolic dyspnea. Sometimes actually a diabetic patient who was not actually maintaining actually the glycemic control adequate, they also have come with actually the dyspnea. So it is a spectrum of symptoms and signs. So we all should emphasize on the clinical features of dyspnea, orthopnea, paroxysmal nocturnal dyspnea, along with the signs like look for JVP, the basic things like what Sir has told, the basic MBBS days what we are taught and everything, which nowadays we are tend to forget because we are more longer actually depending on echo, we are more depending on actually BNP, NT-pro BNP and actually other investigations look on everything. So emphasis should be more on the clinical picture, look for the symptoms of dyspnea or orthopnea or paroxysmal nocturnal dyspnea, and clinically try to look for actually elevated JVP, basal crabs, look for actually some amount of actually pedal edema. With that actually always remember there are actually echo may come normal because most of the echo technicians who are doing nowadays, they don't give importance to actually the diastolic dysfunction or filling pressures and everything. So it is a preserved ejection fraction also comes and everything. So it is the diagnosis of the heart failure. It is a bedside diagnosis. It depends upon the symptoms, syndrome of symptoms and signs and everything. So rightly Sir has told and everything. So whenever a patient comes to you in that and everything, we all actually as physicians, we all actually give actually a widespread actually combined treatment of respiratory as well as the cardiac at the initial stages, and then actually you can take the help of other additives like ECG, echo, and actually old myocardial infarction, risk factors are there and everything. Then only actually BNP and NT-pro BNP. As we all know that actually in India, the affordability of BNP and pro BNP and the availability of the BNP and pro BNP, it is not actually at the each and every actually secondary centers are not at the actually, even at some tertiary centers, they still don't have BNP and NT-pro BNP, they are outsourced and everything. So it is the emphasis is like Sir told that it is predominantly on the clinical actually the symptom of actually signs and symptoms and everything. Now the next thing is once you have diagnosed as a heart failure, how aggressively you are starting the heart failure treatment, and what are the actually inhibitions as a physician or as a treating doctor you have, which medicines you are little bit hesitant in starting, which medicines you feel that I will have to go aggressive. Is there any cutoff like that? If you have expressed your doubts and everything, we all can clear among ourselves.
So I will start on AC inhibitor bar ARB.
So say again, sir.
AC inhibitors are and ARB and ARB.
Okay. So you are asking actually should we start AC inhibitors or ARBs or ARNIs? That's the query, sir?
Huh.
Yeah. So the thing is that actually, sir, all the three are class 1 indication. Whether it is AC inhibitors, whether it is ARB or ARNI are class 1 indications. But efficacy wise, all the trials and everything like actually paradigm trial, PROVID trial or actually your pioneer trial, all these things shows that there is an additive advantage in actually your ARNIs, because they are here, we are not only targeting actually ROS pathway, we are also targeting the nephrolysin pathway, which gives additional benefit of early cardiac remodeling, which says that actually all the studies, even practically I myself have witnessed, there is an increase in ejection fraction of 5 to 10% over an year, which as early as 3 to 6 months we are witnessing. So given a scenario, if there is actually the patient is affordable, the first choice, if the first line of starting the medicines, provided the BP is okay, provided the patient doesn't have got baseline renal dysfunction and everything, the first choice of actually the starting of initiating the heart failure therapy, I would advise it should be ARNI. But remember, sir, in our country, we are all actually bound by actually the cost affordability and the drug availability, and also because by starting actually ARNI, let us say that Vimada or anything you start for today, the patient is buying for 2 or 3 days. After 3 days, the patient is actually not able to buy the medicine consistently and everything, and after in course of time skipping the medicines. Rather than that, at times it is better to start a simple AC inhibitor like actually enalapril and ramipril, so that something is better than nothing and everything. Remember, AC inhibitors or IRBs, they are time tested and they have gone actually towards the actually decade old actually evidences pointing towards the beneficial and everything. So if the cost factor or affordability is the problem, so then in that case, instead of actually starting the ARNI directly, you can actually start ACE inhibitors. But the bottom line is, please start at least any one of them. Even if the BP is normal, at least start a low dose actually AC inhibitors or ARBs, or actually if the patient is affordable, ARNI at the lowest possible dose. Then actually we will titrate over the next 48 to 72 hours based upon his actually BP response, based upon his renal dysfunction and everything happening, based upon his potassium and everything, that we can always actually modify after 3 days. But given a choice, ARNI, because of additional mechanisms and everything, not only inhibiting the ROS pathways, because it also inhibits the nephrolysin pathway, and nephrolysin, as you know, that actually it is one of the endopeptidase which is actually cleaving actually all that actually brain natriuretic peptides, even the angiotensinogen and all those things and everything. So thereby decrease the availability of the good actually diuretic things like atrial natriuretic peptide and everything. So by inhibiting the nephrolysin, you are actually salcubitril gives an additional advantage. And only drawback with actually giving isolated sacubitril is sacubitril will lead to actually increased amount of angiotensinogen, which in turn can cause actually further deteriorating event. That's the reason it always as a combination. And one of these reasons only, when we are switching over therapy from ARBs to actually ARNIs, there is no actually washout period or anything. But always remember, when you are switching over from actually AC inhibitors to ARNI, there is ideally a 36 hours of washout period is needed, so that all the angiotensinogen is effectively taken care of and everything, then we everything. So I believe I have answered, sir. First choice is ARNI, but that doesn't mean that actually IRBs and AC inhibitors are second choice or third choice. All are first choice, but definitely ARNI has got a better advantage than AC and ARB. So that should be your first drug apart from the diuretics. So what could be the next drug that you will suggest, sir,
Beta
at
blocker.
the time of admission?
Beta blocker.
Yes, sir, please.
Beta blocker.
Yes. So the next thing is the beta blocker, but there are actually the two things. One is actually when the patient has presented with the acute heart failure, patient has presented with a decompensated heart failure, when the heart rate is actually 110, 120, if the same patient is having a low ejection fraction, let us say that less than 30% and everything, sometimes we have to stick to the basic hemodynamics that cardiac output belongs on both heart rate into stroke volume. So in the acute condition, when the patient is fully decompensated, all the studies and everything so that we should be little bit actually defensive on the beta blockers. Sometimes you can differ up to 48 hours also on that and everything, so that the patient little bit actually come out of the acute decompensated or fully overthrown fluid overload features and everything. Then actually we can start the beta blockers. However, if the patient has presented in acute heart failure, however, he is not actually full-blown pulmonary edema, he is actually little bit actually able to actually giving actually the BPs are very good high and everything, provided the patient is not having COPD, then definitely there is no wrong in starting the beta blockers. And remember, if there is ischemic cardiomyopathy, if the patient is having heart failure with a predominant actually underlying coronary artery disease and everything, beta blockers remain the first step, because it is not only about the heart cardiac remodeling, we are also looking at the sympathetic drive cutting off and everything, which has got other beneficial advantages as anti-anginal also and everything. So given a choice, we can start beta blocker, but for initiating the beta blocker, I would suggest actually all the people to have actually 24 to 48 hours, you assess individually and everything, and then start the patient on beta blockers and everything. That will be my actually input, sir. But however, if anyone wants to actually add or correct me, I am open to it.
I agree with acute decompensated cardiac failure. acute decompensated cardiac failure, beta blocker should be avoided. If it is a chronic cardiac failure with a background of ischemia, beta blocker would be a better choice.
Absolutely, sir. That's what I was suggesting in everything.
I just want to ask you, what is the aldosterone escape phenomenon? How
Uh,
often you come across?
okay. So the aldosterone escape phenomenon. Honestly speaking, I also actually, whatever the theory and everything, clinically actually I didn't went into much into that. But what is that actually that the theory part of aldosterone escape, what they are saying is, by starting an AC inhibitors or ARBs, because as you see the ROS pathway, your final product, we are here targeting at the final product, the angiotensin 2, which has got effect on adrenals, which has got effect on the sympathetic drive, which has got impact on the sodium potassium actually co-transporter, which has got effect on actually your nephrolysin also and everything. So that actually affect adding on the actually aldosterone. Indirectly, it is giving an idea by starting a AC inhibitors or ARB, we are already blocking the aldosterone pathway. That is, we are already giving an indirect mineral receptor antagonist action. Then why the hell we have to add a separately aldosterone antagonist? So that's where this aldosterone escape phenomenon comes, because as we all know, aldosterone secreted by adrenal cortex, the secretion of that actually aldosterone from the adrenal cortex not only depends upon the ROS pathway, there are some independent to actually angiotensin or angiotensin 2 also, there is some amount of action of actually secretion of aldosterone happens. That amount of aldosterone, whatever, whether it is because of the angiotensin 2 or it is because of the independent of angiotensin, which has got other actually effects like actually arterial constriction by increasing the arterial constrictions, and all the, actually it has got other effects like actually reducing the GFR and other effects like actually for inhibiting the sodium potassium transporter pathway. So by acting that and everything, even in spite of blocking the AC inhibitors ARBs, we might give still some window for actually reducing the benefit of AC inhibitors or ARB by allowing the aldosterone pathway to escape and everything. To plug that pathway only, this agent of actually aldosterone antagonist or mineral receptor antagonist by means of various trial, by Ephesus trial and all these trials, now they have included also in the class 1. If you look into that, actually the heart failure guidelines actually the towards the ages, towards the 60s and 70s, before 60s and 70s, if you all remember, digoxin was supposed to be one of the class 1 agent. But as we go towards the actually that travel towards 80s and 90s and the actually millennium, then actually slowly the digoxin has been withdrawn, where the role is confined only to actually your actually atrial fibrillation for rate control and everything. Apart from that, the first one actually which has come into the play is the diuretic, then actually the AC inhibitors comes, then the beta blocker come. Towards the 90s only and everything, this aldosterone escape pathway was actually found out and everything. Then they started giving importance for that and everything. Then the receptor antagonist, mineral receptor antagonist has been included as a class 1 indication. And then actually subsequently we know that actually a few years back and everything, ivermectin also has come into the play and everything. And it is in the last 2 years, now SGLT2 inhibitors also has been included into the as a class 1 indication for heart failure patient. That's the reason nowadays, if you take the guidelines directed medical therapy, that is a GDMT, for a person with heart failure means there should be a checklist of these 5 medicines. The number 1 is your AC inhibitors or ARBs or ARNI. Number 2 is your beta blockers. Number 3 is ivermectin. And number 4 is actually your aldosterone antagonist. And the plus R1, the 5th is, even though no mortality benefit, but in view of recurrent reducing the hospitalization and morbidity benefit, simple loop diuretic. So this is how we transcended everything. And that's how that aldosterone escape and everything has made us to think that we have to give additional actually aldosterone production antagonism and everything. The aim is go as a full board and attack towards the heart failure remodeling at the earliest possible, and then try your best so that even 5% improvement in ejection fraction. You all people might have, in your clinical practice, you all would have appreciated that there is actually the patient who was actually that, especially in a MI, post-MI patients, initially when the LV dysfunction was 40%, over the 3 to 6 months when their actually heart function has improved to actually a normal of 50-55, how much actually just a 5% or 10% improvement in ejection fraction has got a significant improvement in the patient's lifestyle and mortality and morbidity, and almost actually recurrent hospitalization and regular actually their work capacity, physical capacity, everything enhances. So that's the reason Now it is the emphasis is on you go for full-blown guidelines directed therapy and add aldosterone antagonist irrespective of giving a separate ORNI or ARB or AC inhibitors. However, both these drugs, whether it is ARBs or AC inhibitors or ORNIs or actually aldosterone, both the things, there is a catch-hold that we always have to start at the earliest possible, and along not only starting at the earliest possible within 48 to 72 hours, we have to recheck the actually RFT, potassium and RFT to see that actually the patient is tolerating this or not and everything. Can we go ahead and everything? In cases where we are not able to go ahead actually with the AC inhibitors or ARBs or ORNIs or aldosterone antagonists, that's where your isoleucine, because which doesn't have got effect on actually anything, which is a potent vasodilator, both actually central as well as the peripheral vasodilator, the combination of nitrate and hydralazine, that has taken as a class 1 indication where we are not able to reach the maximum dose or where we are not able to judiciously use AC inhibitors or ARBs or your aldosterone antagonist. So that's how the aldosterone is good, sir. So the first choice, like you told, is it is AC inhibitors or ARBs or ORNIs. The second drug, always the beta blockers have to be kept in mind, and the third drug we have to start in the acute decompensated heart failure is always has to be a mineral receptor antagonist along with judicious use of diuretics in the first acute decompensated state, sir. Yes, sir, you wanted to say something, sir?
When we give beta blocker, what is the rationale of adding ivabradine to reduce the heart rate?
Yes, sir. So rationale of adding ivabradine is, so ivabradine, once again we are looking at actually rate reduction. Now, like already I told that in the acute case we are looking at the Frank-Starling's law of cardiac output is equal to stroke volume into heart rate. However, in the long term, I always told that it is the diastolic component we have to everything and the filling process. So there has to be adequate diastolic filling phase has to be there. If you look at the cardiac cycle, the 0.8 second of one cardiac cycle, the predominant part is actually diastolic. But however, if the heart rate increases in everything, which will reduces the diastolic filling time. By reducing the diastolic filling time, invariably we are going to actually decrease in the cardiac output. So that's the reason actually to increase the filling, diastolic filling, to decrease the increase the diastolic filling time, we have to reduce the heart rate. So in the heart rate reduction, like you are told that the first choice of drug for heart rate reduction is always going to be a beta blocker, because we are not only looking at the heart rate reduction from the beta blocker, we are also looking at actually a sympathetic drive actually knocking off and cardiac remodeling from the beta blocker. But however, suppose we have reached the maximum tolerated dose of beta blocker, or like you told that in acute decompensated state where we are not able to use the beta blocker because we are very scary that not only we are going to reduce the cardiac cardiac output stroke volume heart rate formula, but also if at all some bronchoconstriction happening and everything, which will cause the pulmonary interstitial edema to worsen and everything. So that is the reason actually in the acute case it is always better to start the ivabradine and then actually overlap along with the beta blockers. After that actually overlapping ivabradine with the beta blockers, then your entire focus and emphasis should be on the beta blockers. You keep on uptitrate to the beta blockers. Remember, in the heart failure treatment, as far as the guidelines directed medical therapy, it is always the maximum tolerated dose. So when I am saying maximum tolerated dose means for ARNI or Vimada, we are supposed to reach a maximum of actually up to 100 milligram BD, and for actually if you are using actually enalapril up to 20 or ramipril up to 10 milligram, and same thing actually holds for beta blocker also. If it is a carvedilol, you are going to reach maximum 25 milligram BD, or if it is a metoprolol, maximum 100 milligram OD. So we have to reach the maximum dose. But in spite of reaching a maximum dose, when the patient is actually stable, from the stage D, the patient has come to actually stage 3 of the heart failure. When the patient is from NYHA4 has come to NYH3A, but still the resting heart rate is more than 70, then actually once you reach the actually beta blockers, then you touch the ivabradine. For example, if initially you start the ivabradine with 2.5 milligram BD, increase to 5 milligram BD, and then you can go up to the maximum of 7.5 milligram BD. So your aim is to keep the heart rate in stable patients as low as possible, resting heart rate as the less than 60 to 70, around 60 to 70, and exertional heart rate around actually 70 to 80. By keeping the resting heart rate and exertional heart rate under the actually check and everything, we are going to increase the diastolic filling, which have got beneficial effect in the cardiac output and hemodynamics. That's where actually ivabradine, predominantly causing a sinus node inhibitor, IF inhibitor, IF channel blocker, it has got a beneficial role actually in reducing the heart rate. And the advantages of ivabradine over actually beta blockade in the acute decompensated failure is, since it doesn't have got interference in the pulmonary and all the interstitial and everything, so we can start ivabradine at the earliest stage and everything at 2.5 milligram BD or 5 milligram BD, and then overlap with the beta blocker. But after that, you don't touch actually ivabradine unless you reach the maximum tolerated dose of beta blocker and your resting heart rate is around 60 to 70.
Okay. Now, one more question regarding the MRA.
Yes, sir.
There are two things. One is selective MRA, that is eplerenone, and non-selective spironolactone.
Yes, sir.
When you have a selective MRA, why we are using spironolactone very frequently in our practice?
Very good question, sir. Since the mineral receptor antagonists, ideally, broadly, they are classified into two major groups nowadays. One is actually steroid dependent, steroid based actually mineral receptor antagonists, and then non-steroid receptor actually NS non-steroidal actually mineral receptor antagonists. There is one new drug is coming like finerenone, which has got efficacy that. The thing is that the non-steroidal and steroidal difference is basically steroidal actually mineral receptor antagonists, they causes hyperkalemia. Non-steroidal mineral antagonists, there is a less incidence of hyperkalemia. That one point. Now coming to the steroidal incentive, one is the highly selective actually mineral receptor antagonist like eplerenone. Another one is a non-selective mineral receptor antagonist like actually your spironolactone. The difference between them two is actually pharmacologically and everything is both has got equal efficacy for actually cardiac remodeling. Both has got equal actually risk for hyperkalemia. The only difference between actually for the pharmacodynamics and everything between eplerenone as well as spironolactone is spironolactone has got other additional action of anti-androgen action. That's why actually the patients who are on spironolactone, they have got gynecomastia. But the why we are predominantly using spironolactone rather than eplerenone, once again it's the cost factor comes into place. And our friends who are actually organizing the talk today, they will give a better upload of what is the cost of one ditar plus and what is the cost of one ditari. And I remember actually eplerenone actually it cost around 10 to 12 na eplerenone 25 Naveen or Srikanth.
Yes, sir. Sir, eplerenone alone it cost itself 24 rupees, sir.
Yes. So same thing. What is the cost of simple aldactone 25 or 50 milligram? Hardly 1 rupees or 2 rupees.
Cheapest.
Yes. So that's the once again we are actually now being an Indian country. We always actually you start on eplerenone and after 1 week the patient stop the medicine, doesn't take actually eplerenone, doesn't take ditar, and he comes again once again with another heart failure admission. To avoid that things, sometimes we have to think in everything. But as a cardiologist or someone sitting in a very corporate or high field dealing with the affluent population and everything, it is always better to go with a ditar E and everything. Now the benefit of ditar eplerenone over actually spironolactone is there is no anti-androgen effect. Otherwise, actually, the bioavailability and everything, they are telling that actually longer actually the bioavailability little bit has got eplerenone. But however, overall difference between eplerenone as well as actually your spironolactone in cardiac remodeling remains the same. The risk of hyperkalemia also remains the same. That's where actually the non-steroidal mineral receptor antagonists like finerenone, they have come into play of actually taking off reducing the risk of hyperkalemia. But once again, being a country from India, I think actually the affordability and all those things are factors. So as of now, if at all you are starting the patient, look at the cost affordability and longevity of the patient and everything. If you feel that actually he is from software, he is from actually affordable family and everything, start eplerenone. That is better than actually spironolactone. If it is not there, go to spironolactone. That's the reason I always told you first, sir. Whenever we are starting the patient, if the patient is actually affordable and affluent and everything, our initial treatment should be apart from the diuretics, it should be actually Vimada. There should be a beta blocker, there should be ivabradine, and there should be actually your eplerenone, and along with it, you have to start SGLT2 inhibitor, even if it is a non-diabetic also, dapagliflozin also. The same thing, if the patient is coming from a very poor community and everything, where actually the cost and actually the continuity of medicine is little bit doubtful, where the patient may go back to actually government to get the medicines and everything, start the diuretics, apart from the loop diuretics, you put the patient on actually either ramipril or enalapril, along with the patient, put the patient on aldactone, and along with it actually, if it possible, put on ivabradine and SGLT2 inhibitors. But once again, at least there should be an AC inhibitors, there should be a beta blocker, and there should be a spironolactone along with the loop diuretic. These 4 tablets easily available from most of the government pharmacy and everything, and for them affordability also will not be a problem. But in a given a population, if you wanted to strictly adhere to the guidelines related medical therapy, you strictly follow, start the dapagliflozin or empagliflozin, start Vimada, start eplerenone at the beginning. So that's what actually, even when these people approach me also, that is what I always tell and follow in my actually practice also. If I sense the patient is affordable and everything, go for the best possible medicines. And there are some people actually, nowadays actually Google and all those things, multiple opinions taking here and there and everything, they will come with the why not we started that and everything. To shut the mouth of those people also, go for the best possible therapy in such people. But remember, most of our actually private practice or most of our clientele, still more than 50% comes from the poor public and everything, little bit even the middle class family, where the long term affordability of these medicines become a big question mark and everything, and there is a possibility of discontinue of the medicines. So for them we should actually stick to the basic medicines, and then actually that's why. But on this point, one more topic also which is not related and everything, among the loop diuretics also, definitely if the patient has got renal function is normal, your torsemide is proven much more efficacy and longer bioavailability and better pharmacodynamics and longer half life than your actually furosemide in OPD practice and everything. Even in the IV setup also and everything, torsemide is a better diuretic effect and everything. So that is actually one thing which is not that much costly and everything, which we all should look into the pay and everything. The difference between the furosemide and torsemide in the clinical applicability is only when the creatinine goes to beyond 2.5 and everything. Since there are not much studies from actually torsemide as a choice of loop diuretic, there we have to go back to furosemide and everything. Otherwise, my only request to all the people who have started everything is, whenever you come across a patient with a heart failure, initially stick to the standard diagnosis of actually clinical spectrum of symptoms and signs. Once you feel that actually the patient has got a component of heart failure, the patient may be having associated COPD, patient may be having associated actually diabetic component, but still actually if you feel that the heart failure treatment and everything, initiate the heart failure treatment at the earliest possible at the time of admission itself with a simple loop diuretic, mineral receptor antagonist, ACE inhibitors or ARBs or the RNAs, along with actually ivabradine or plus or minus actually beta blockers. Once you get actually a confirmation of diagnosis, a echo or with a beta with actually BNPs and everything, then subsequently next days you can actually add actually dapagliflozin and the beta blocker choice of starting also and everything. You can decide whether it is at time of admission or it is after 48 hours, depending upon the extent of decompensation in the patient. And the another one point that we have to cover in today's topic is how frequently you have to titrate and everything. Like I already told you, sir, remember the guidelines directed medical therapy is the maximum tolerated dose. So maximum tolerated dose, unless we reach and everything, we have to keep on increase the dose. So the guidelines are saying that every 2 weeks we have to keep on initiate. But once again, the cost factor, the follow-up our patients and everything. So if not monthly 2 weeks, at least actually monthly once actually you try to escalate the dose and everything. But always remember, when the patient is admitted with you, definitely there is a 3 days of window period. He will strictly follow your advice. Make sure that you start that actually ACE inhibitors or ARBs or RNAs and mineral receptor antagonists at the time of admission itself, so that before discharge at least you could have checked and everything what is his response with the renal profile, whether he is tolerating it everything, whether he is developing hyperkalemia or not and everything. And at the time of discharge you can see the ECG, see the heart rate, how far, whether you have reached then the resting heart rate of 70 to 80 and everything. You can fix the dose, further escalation and further rechecking. Though the guidelines say that it is once in every 2 weeks and everything, in Indian condition you can be little bit lenient of monthly once, but don't left your patients unmonitored beyond 1 or 2 months whenever the patient is on actually mineral receptor antagonists, that is eplerenone or spironolactone, all ARNs or ARBs beyond 1 or 2 months. At least in the first 3 to 6 months, make sure that it is monthly once or once in 2 months follow up. But once we reach the maximum tolerated dose and we have seen that the patient is tolerating well, then option that it is only once in 3 months or once in 6 months review is more than sufficient. And one more important thing is early initiation of all the definitive heart failure treatment. Definitely there is a lot of beneficial and lot of actually improvement in the heart function also, and most importantly, it will definitely reduce the recurrent hospitalization. Most of the times we are coming across people who are discharged, they come after 2 weeks and everything, because the reason is before we have optimized the dose, they have went on DAMA, or sometimes it is our mistake, we didn't keep a follow up on those patients without how to actually titrate the diuretics and everything. Remember, I already told you, among the guidelines directed medical therapy, the loop diuretics is the one lowest range and everything. So initially you may go with a very high dose of actually, for example, furosemide, you may go up to 100 to 200 milligram per day in the initial first 1 or 2 days. But before discharge, we have to bring down to as low as possible, so that to keep the patient dry, so that to keep the patient's burn or creatinine under check and everything. So that is the one actually I would like to suggest. I think already we are crossing the time, and being a Saturday end, maybe other audiences, everyone can input or anything else we have missed out.
One more, this regarding stable heart failure.
Yes,
Patient
sir.
is decompensated. We have stabilized him.
Yes, sir.
Is CAG and PCA is by default done?
Pardon, sir. Say again, sir.
Once we stabilize the heart failure,
Yes, sir.
PCI or CAG is by default, it is done on a routine basis to see for ischemic.
Yes. The thing is that for all dilated cardiomyopathy, all the patients with the cardiomyopathy or LV dysfunction, remember one thing, the most important, easily reversible cause of cardiomyopathy is the coronary artery disease. So all patients with actually cardiac failure, whether it is a preserved ejection fraction or it is actually reduced ejection fraction or mid-range ejection fraction, ideally after stabilization, we have to do an angiogram so that we rule out the reversible part of ischemic heart disease or coronary artery disease is addressed immediately at the then and there. That itself will help to actually improve the future and everything. So that's why actually for all the patients with actually cardiac failure, after stabilization, it is better to do an angiogram and actually address that actually ischemic part and revascularize. However, there are some entities which most of the, like in our day-to-day practice, we come across actually cardiac failure where actually it is a predominant the dilated cardiomyopathy, where all the four chambers are dilated, it is completely thinned and everything. In those patients, it is always better to see the viability first before going for angio or revascularization. And if the patient is affordable and everything, in such conditions, along with guideline directed medical therapy, we may actually advise actually ICD also and everything. And if the patient is having LBB, definitely there is a role of CRTD which has got definite beneficial in improving the outcome, because in my clinical practice there are two drugs which I feel myself actually improving the LV ejection fraction over a course of time, which other things have not done. One is your Vimada or Arni, the another one is actually your CRTD. Both have actually clinically improved the ejection fraction by 5 to 10%, and most important is improvement in the patient's life and everything. So before going to that and everything, all the patients, the reversible cause, the most important and most common reversible cause is the ischemia. So it is to address that ischemia, it is better to do an angiogram after stabilization after 2 weeks.
Okay. One clinical scenario can I share?
Please, sir. Please, sir.
Okay, my mother-in-law, she is 80 now.
Okay,
She
sir.
was hale and healthy, and for the past 3-4 years, she has symptoms of heart failure, diagnosis dilated cardiomyopathy. When I went to the ECG, there was LBBB. I
Okay.
strongly suggested for CRT.
Okay.
After CRT, her ejection fraction has come up from 20 to 40 now. She is
Yes.
comfortable.
Absolutely. That's what I am telling, sir. For a patient with actually DCM with LBB, definitely there are two things only. In my practice, actually, my personal experience also, I have seen the actually improvement in ejection fraction. One is the CRTD and another one medicine. Don't ever underestimate ARNI. ARNI is really actually, initially we didn't thought that this much benefits. Nowadays, actually, the studies which are coming up and everything, and clinical practice also is showing that significant improvement in LV ejection fraction around 5 to 10% over actually 6 months to 1 year with the ARNI. So the thing is that actually CRTD, that where if the patient is affordable and everything, you go for as much intervention as possible. But when you are not having affordable and everything, if you want to give best possible medical treatment, stick to the guidelines directed medical therapy, in which all the 5 ingredients has to be have the part role in playing. Anything else, sir? Anyone else? Anyone want to ask or anyone want to share anything else?
If none is there, one more of my patient,
Okay, sir.
58-year-old. Last week he came with orthopnea.
Okay.
For the first time I saw him,
Okay.
and clinically I diagnosed left ventricular failure.
Okay.
Then gave some first aid like diuretic, beta blocker, everything.
Okay.
Shifted into a tertiary care unit. Echo
Okay.
showed aortic stenosis. He
Okay.
underwent TAVI and now is doing extremely well.
Yes. That is actually, sir. So in that patient, actually, the cause of the heart failure is more than that actually reduce the ejection fraction and everything. It is an obstructive disease. So
Maybe
always that's the reason. Pardon, sir?
obstructive reason for
Yes.
cardiac
So
pain.
that's the reason. Whether it is ischemic or obstructive, any correctable etiology, always actually we should relieve that actually reversible cause. If anything is there, address the reversible cause. Only when there is a non-actually is reversible causes and everything, where we have to go aggressive on the medical management, where we have to go aggressive on device therapies like ICD or CRTD.
Thank you so much for all the information.
No problem, sir. Pleasure is mine, sir. And what about the others, sir? Anyone is having any other inputs or any suggestions?
Good evening, sir. Dr. Karthik here. How are you doing,
Yeah,
sir?
Karthik, how are you?
Good, sir. Good, good. So it's just it's a very good discussion. All the points are covered. I just had a small query. So
Yeah, please.
when you're treating this thing, heart failure especially,
Yeah.
so with respect to, as you told, we rely recently more on a BNP as well as a pro BNP.
Yeah.
So certain times we do see that like only the BNP is elevated, and patients may have a mixed COPD
Yeah.
as well as
Yes, yes.
CHF. So in such a scenario, how often do we keep a track on the BNP? I mean, do you do it at every follow-up, or because the COPD part is always there, so they will always have a like sometimes they might have a nighttime awakening because of COPD. So in such a scenario, does it make sense to do BNP on every follow-up along with the echo, or rely more on clinical criteria itself?
Yeah, Karthik, in that first is always the clinical parameter number one. But the BNP definitely has got a role. Remember always, in the patient with CKD or the patient is obese or underlying COPD, we are not looking at the cutoff level of BNP of actually 100 or 200, what we look at in the conventional population. Here the cutoff level, what we have to keep it is little bit on the higher. But during the course of follow-up, if from the baseline, for example, in a normal population, we are keeping 100 as the cutoff for BNP. In these people, you keep a cutoff of around 200 to 300 as a cutoff. But if that cutoff significantly increases twofold or threefold, in that case, definitely we can confidently say that this time, this particular time, his exacerbation of symptoms is the heart failure is the predominant dominant player than the COPD player, because most of the times we are all stuck up with the dilemma whether this time actually this patient is admitted, it is the COPD is the dominant player or it is the heart failure, because most of the patients will have combined manifestations. All the patients will have mixed disease, because we are not dealing with one particular disease. We are dealing with a human being, where the patient with the DCM with severe LV dysfunction, he is also a smoker and he will be having a COPD also. So whenever you have got a dilemma of whether it is a dominant player is the COPD or dominant player is actually the heart failure, always it is actually first and foremost rely on the clinicability, but always it is very difficult to actually judge on the clinical per se in such patients, because overlap is so much overlap, we will be very difficult to actually pinpoint towards the particular entity. So that time you do a DNP, have a baseline BNP as a cutoff level and everything, and see whether there is a rise in BNP or 2 to 3 folds and everything. And most of those people will have, along with it, there will be acute exacerbation of COPD, which is precipitated by another infection or sepsis component. Another one component, sepsis component also will be there. When you have got a doubt in which we have to aggress, whether we have to go aggressive on diuresis or whether you have to reduce the diuresis and go aggressive on the fluid management and everything, take the help of procalcitonin also. See holistically, see that actually how far the BNP is elevated, how far the procalcitonin is elevated. See the clinical feature of how much he is dehydrated or fully wet or dry or the patient. Based upon that, you decide upon the diuretic or fluid management. because moment actually is established actually COPD plus heart failure management, your baseline management on beta blockers or your AC inhibitors or ARNIs or ivabradine or aldosterone, they are going to remain the same. Only the dilemma in the acute stage is how much aggressive we have to go for diuretics, or should I go for fluids because I am feeling that sepsis and everything. To rule out the dilemma and everything, apart from the clinical, take the help of BNP and serum procalcitonin.
Sure. Thank you, sir. Another one question.
Yeah.
So we recently saw a lot of people with post-inflammatory cardiomyopathy, like post-COVID, and certain times unexplainable. So we have seen a role of ARNI in those cases. Your experience with MRA in those cases, sir? ARNI, we have seen that it helps a lot. So we have seen a lot of people recovering very, dramatically and very significant improvement with ARNI. But
Yeah.
with MRA, your experience, sir?
Nice. All these actually MRAs or beta blockers or AC inhibitors and everything, it is actually we are not able to see actually clinically in a short term period and everything. And these actually, all these actually the first line of guideline directed medical therapy, the class 1 indications, they have got their role because of the long term actually the benefits and everything over that and everything. But the COVID being a very short of the last 2 years or 3 years, we are actually predominantly looking at the drugs which is giving actually a fastest possible actually benefit and everything. Like I already told you, the fastest possible benefit among all the medicines, invariably remember to realize with the ARNI only. And apart from the ARNI, the another one drug which has got actually a very potential effect in remodeling, in preventing ischemia or thrombotic events and everything is in high risk population, where as a physician you will be having a better knowledge than me in selecting very high risk COVID patients, put them on actually a direct reacting anticoagulations, oral newer and oral anticoagulations, rather than putting them on antiplatelets and everything. That has really helped in endothelial modification and everything, preventing from actually going for actually that subacute thrombotic level or actually subsegmental thrombotic level and everything, beneficial effects and everything. So in that, the clinically whatever we are seeing, observing is only actually Vimada. Apart from that, actually all other medicines, definitely they have got actually beneficial role, but it is too early to see the maximum benefit in such a short duration.
Thank you, sir.
Anyone else? Or Srikanth, can we close it? Naveen?
Yes, sir. Yes, sir. We'll wait for 2 minutes, sir. If any question, any query, we'll take it. Otherwise, we'll close it, sir.
Short question from my side, sir. I'm Dr. Divakar. I'm a physician.
Yeah, please, sir.
Sir, so patients who have been discharged post a heart failure admission and those who are diabetic and not put on SGLT2 inhibitors. Okay. Now, once we start them on SGLT2 inhibitors after the stabilization of heart failure, how we would like to reduce the diuretics after the initiation of SGLT2 inhibitors?
Okay. Firstly, sir, actually, diuretics, I already told in my previous actually the discussion also, the loop diuretic, it is always flexible. There is no such thing called maximum tolerated dose from the loop diuretic. Loop diuretic, the maximum dose is at the time of acute decompensation. Subsequently, we are going to reduce it to a stage where it is a maximum possible dry state, and with the preservation of renal function parameter, we are going to reduce our both furosemide or torsemide dose. So when we are starting SGLT2 inhibitors, keep that also into everything, because we are once again SGLT2 inhibitor, we are going to go into a diuretic, negative actually load and everything. So if we are already actually, for example, if the patient is already tolerating at the dose of actually, let us say that furosemide Lasix 40-110, now we are going to discharge with the Lasix 40-110, and that is the stage you wanted to start SGLT2 inhibitors like dapagliflozin or empagliflozin. You don't discharge the patient with actually the same dose of furosemide which you have thought of previously. You can reduce the dose. Definitely you can reduce the dose. Remember, this actually loop diuretic dose, it is going to be case to case basis, and it is your individual actually experience and everything in due weightage to your bund level or blood urea level and clinical actually weight drain, everything, how much pedal edema is persisting, how much the patient is actually functional capacity related, how much urine output negative balance you have already achieved and everything, whether now the bund levels are going high and everything. Based upon that, you are going to decide the dose of that and everything. So when you are starting SGLT2 inhibitor, definitely you have to slightly reduce the dose in keeping it in mind and everything. But always remember the other drugs, whether it is AC inhibitors, ARBs, or ARNIs, or beta blockers, or your mineral receptor antagonists, they are not going to be touched and everything. They are going to be keep on increased at the maximum tolerated dose. For loop diuretics, there is only in acute decompensation you go as high as possible. For Lasix, actually, that's what I always tell. If you are going to give a Lasix as a loading dose, anything less than 80 to 100 I never accept as a loading dose and everything. People actually in the casualty, they give 20 milligram or 40 milligram. They are just actually a peanuts for a person who has come with a full blown pulmonary edema and everything. So go aggressively in the first day. You start actually even at a furosemide infusion or actually torsemide infusion at 5 to 10 milligram per hour, even reach up to 200 or 240 milligram of maximum dose in the first acute stage. But at the time of discharge, there are lots of patients I discharge even only with 40 milligram of Lasix or actually 20 milligram of actually torsemide, but other medicines would have been actually at least reasonable tolerated dose. So this medicine, keep in memory about the SGLT2 inhibitors also. And that's the advantage of SGLT2 inhibitors. You can start at the time of acute decompensation also, provided the creatinine is not more than 2.5 or the patient is not a CKD patient. So you can start even in the acute decompensated state also.
What are the indication for cardiac transplantation?
Yes, sir.
What are the indication for cardiac transplantation in a heart failure?
Okay, so indications for cardiac transplantation, as far as from the heart failure kind of thing is, it is a refractory heart failure or stage T heart failure. That is, when you are saying a refractory heart failure means you have given actually at least actually 6 months of time with the maximum tolerated dose of guideline directed medical therapy, or provided you have ruled out actually any reversible ischemia, provided you have considered actually the patient is not a candidate for CRTD or the patient is not a candidate for ICD, because if the patient has got actually other actually conditions like apart from ejection fraction, there is a pulmonary pressure also is going up and everything, or the patient is having some amount of mild valvular disease also is there and everything. So that is the only indication for actually heart transplantation as far as the point of actually refractory heart failure is concerned. But otherwise, there are other conditions like actually some congenital heart diseases also, acyanotic heart diseases, and apart from that actually there is actually refractory valvular multivalvular heart diseases. There are indications of everything. But as of now, the predominant indication for heart transplantation is refractory heart failure. When you are saying a refractory heart failure or stage T heart failure is, you have tried actually maximum guideline directed medical therapy for at least a course of 6 months, and you have ruled out actually reversible causes like ischemia and other causes effectively.
Thank you.
Any other actually, is there any other actually inputs or any queries? If it's not there, we can close. Already it is 9:30.
Yes, sir. Yes, sir. Yes, sir. Sir, once again, on behalf of CIPLA, thank you very much, all of you, sir, for your participation and time for this meeting. In coming days, also we'll plan like these meetings and we'll do it, sir. Thank you once again from behalf of CIPLA. Thank you very much, sir.
Thank you.
Thank you very much.
Yes, sir, you can log out now. Rhythm team, yes, you can close it now.